Am I audible to you?
Yes.
Okay. Good evening, everyone. I'm Dr. Nirukshi Fernando, and I'm pleased to serve as the moderator for today's CME program organized by the CPD Committee of the College of General Practitioners of Sri Lanka. A few housekeeping announcements before we begin. Kindly keep your microphones muted throughout the session to minimize background noise. Please don't share your email addresses in the chat box. The e-certificates will be sent to your registered email address within 2 weeks. You are welcome to post your questions in the chat box during the lecture, or you may unmute and ask your questions during the Q&A session at the end. Thank you for your cooperation. Let us now begin today's session. It is my great pleasure to introduce our speaker for today's session, Dr. Mizaya Cader, Consultant Community Physician at the National Program for Tuberculosis Control and Chest Diseases under the Ministry of Health, Sri Lanka. Dr. Cader is a specialist in public health and currently serves as the technical head in the Planning and Strategic Information Management units of the NPTCCD. She brings over 20 years of experience in public health with nearly 13 years dedicated specifically to tuberculosis control, serving in various capacities from district level to national leadership. She has also contributed internationally, having served as the National Professional Officer for Neglected Tropical Diseases at the World Health Organization Country Office in Sri Lanka for 2 years. At present, she is an expert on the WHO roster of TB consultants for the Southeast Asia region and a member of the Southeast Asia Regional Technical Advisory Group on Tuberculosis. Today, she will be speaking on the topic, Frontline to Finish Line, the role of general practitioners in ending tuberculosis in Sri Lanka. We are truly honored to have her with us this evening. Dr. Mizaya Cader, over to you. Madam, you're muted. Madam, your mic, okay.
Can you hear me?
Yes, madam.
Okay, right. Thank you, Dr. Nirukshi. Good evening, everybody. So today's session is basically on frontline to finish line. So you must be wondering why, being frontline workers, why we are talking about a finish line as well. But when we consider tuberculosis care, it is a cascade of care, and your contribution is can be incorporated into different levels of care cascade. So let's start the session. Okay. Just give me a second. I'll stop share and again reshare because my slides are not moving. Can you see my slides?
Yes, madam, we can see.
Okay, so this is the outline of today's presentation. Basically, I'm going to talk about what is tuberculosis. I know all of you know what is tuberculosis, the clinical aspect, and some different aspect also I really wanted to highlight. And secondly, global and local epidemiology. Then the NTB targets and strategies to end TB. And finally, as what I meant by frontline to finish line and how you can contribute to ending TB. Okay. So, as you all know, tuberculosis is an infectious disease, a well-known thing, which is caused by Mycobacterium tuberculosis bacillus, which is a very slow-growing organism and spreading through droplets when we were coughing, laughing, etc., sometimes sneezing. So, it most commonly affects lungs, that is pulmonary TB, but it can also affect other parts of the body except hair, nails, and teeth, that is extrapulmonary TB. So mostly TB lymphadenitis, meningitis, TB pleural effusion, intestinal TB and TB spine are commonly reported in Sri Lanka when we consider extrapulmonary tuberculosis. So, okay. So this is about TB infection and active TB disease. Uh, uh, a situation we should understand very clearly because always we get confusion with TB infection and TB disease, and we try to use TB infection diagnostic test and try to identify TB active TB disease. So as you all know, all of us can expose to TB bacilli, but we all won't get the latent infection or active TB disease because mostly because of our immune response, the bacilli is getting eliminated. But rarely, it's less than 5% of people, the bacilli can enter the lungs and can form granuloma. As we all heard about gonfoci, the granuloma together with hyaline-lymphadenopathy, it's primary TB. This is called the latent TB infection. At this stage, you don't show any symptoms. You can't spread the infection from one person to another person. If we do this TB diagnostic test like sputum smear, molecular test, culture, all negative. But if we do TB infection test like interferon gamma release assay or TB skin test, it will become positive. So this is called the latent TB infection. Those days we spoke only about latent infection and active TB disease, but now we are talking about another stage of TB disease, that is subclinical TB. Here also the patient shouldn't show much symptoms, sometimes no symptoms at all, but there could be risk factors like immune deficient conditions, but accidentally we find them to have TB by when we do the chest x-rays. So we are talking a lot about subclinical TB now. That's why we are promoting doing chest x-ray also when we suspect TB or when we think this could be TB or they are from TB high risk areas. So finally, it can progress into active TB disease. So again, this little bit about pathophysiology, I know all of you know and very familiar about this. Earlier I told about primary TB. Very small percentage can straight away progress into primary tuberculosis from the latent TB stage. That is those who are having severe immune deficiency, small children. So those are the people who are having that risk. But majority, what happens, otherwise it is getting healed or it can be calcified or sometime it can progress into secondary tuberculosis or cavitatory tuberculosis if the dormant stage is getting reactivated or reinfected. So there could be 3 sequelae, can be healed, can be formed a calcification, or else it can stay as a dormant stage, which we call latent TB infection. So finally, it is getting reactivated. So then we called cavitatory or tuberculosis or infectious tuberculosis. At the same time, the foci can filter into a lymphatic system or blood vessels, and it can go spread all over the body, sometimes only to the lymph nodes, sometimes to other organs, or else it can cause disseminated TB. So these are the main symptoms of pulmonary TB. We can categorize it as respiratory symptoms as well as constitutional symptoms. So prolonged cough, shortness of breath, chest pain, and hemoptysis. And constitutional symptoms are fever, loss of appetite, loss of weight, fatigability, night sweats. These are the constitutional symptoms. So let's go and see who are vulnerable for TB. I really wanted to add this slide there because TB is a disease which is very closely related to social determinants of health. It's not a mere disease because when we analyze the risk factor, a lot of social risk factors, environmental risk factors, and biological risk factors are there. So basically the biological risk factors are the factors which can cause immune deficiency, like people living with HIV, diabetes, CKD patients, and those who are taking long-term immunosuppressive therapy, and those who are doing organ transplant, malnutrition, extreme age group like less than 5 years, and elderly people. Again, there's a certain environmental condition which has a more risk to have TB. That is overcrowded households like urban slums, detention centers, prisons, those because of the congregate nature of the settings, and homeless shelters, also because of the environment, because of the occupation. Frontline healthcare workers as well as people who are working in silica mine are having exposure, additional risk. And there are behavioral risk factors like smoking, alcohol use, drug use. At the same time, extreme poverty and undernutrition is also can be categorized as social risk factors. So TB risk increase when biological vulnerability overlaps with either social or environmental vulnerability. Again, I should highlight this also. TB is not a mere infectious disease. The consequences of TB, the impact of TB is immense. It can affect an individual's physical, social, psychological, and economic well-being. Not only that, the family well-being, the family economic situation, as well as it's a burden to the healthcare system as well. So physical, as you know, they get weak, they get fatigued. So because of that, their functionality will go down. Social, anxiety, stigma, discrimination, strained family relationship, and psychological. There are a lot of patients who are undergoing anxiety, depression. Some are attempting suicide because of stigma and loss of self-confidence and self-esteem. And definitely economical consequences because people, most of them are daily wages, they lose their jobs, so their income will go down, and it goes as a vicious cycle in their family. Okay, now let's move to the second part of the presentation, that is epidemiology of TB. So although in Sri Lanka, TB is not a high burden country, our country is not a high burden country. Globally, TB is a very prioritized disease. So if we take the global condition, about 1/4 of the global population is infected with TB. Every year, around 10 million, around 10.5, 10.7 million are estimated to have TB. And out of that, actually the reported number is 8.3 million. So if we list out all 10 causes of death, TB is also within that 10 causes of death. But if we list out the infectious cause, TB is the number one leading killer in the world. Only second to the COVID-19 during that 2 years. Again, TB took its the prior place after 2022. So 54% of people who develop TB were men because their exposure is high and they are carrying a lot of risk factors. And out of all TB cases, around 390,000 are having drug-resistant TB, rifampicin-resistant or multi-drug-resistant TB. Altogether, 1.23 million died of TB in 2024. This is based on the 2025 global TB report, but the case fatality rate was very high. It is 11.5%. So these are the countries with high TB burden. If we take 8 countries, I have named those countries: Pakistan, India, Indonesia in our region, again China, Bangladesh, and Philippines. So all together they form the 2/3 of the global TB burden. If we take our region, that is Southeast Asia region, the region is carrying around 43% of the TB burden in the world. Right. So let's move to the epidemiology situation in Sri Lanka. So TB is a very old disease in Sri Lanka. In 1901, we established the TB Commission. That was the first unit we established in PETA. We established to work against TB, to work as a control program. So you can see the 25-year history I have mapped here. The trend is almost slow, sluggish. It's almost stagnant. Year-to-year reduction is very minimum because without any strategic intervention, targeted intervention, and novel methodologies, it is very difficult to reduce the TB curve. So this is the 2 years COVID-19. Again, we picked it up partially. By 2023, we have picked it up fully. Then again, it is started to drop. So you can see in 2025, 8,726 TB cases were reported in the country. Then the third green line is new TB patients, because this is from our surveillance system. 93% of all TB cases are new TB patients. From that, 50%, 75% pulmonary TB and 25% extrapulmonary TB. If we take pulmonary TB, majority are bacteriologically confirmed pulmonary TB, that is infectious pulmonary TB. A certain proportion of pulmonary TB is diagnosed clinically. Although bacteriological confirmation is not there, the treating clinicians, the chest physicians, are having the ability to diagnose them clinically. So this is geographical distribution within the country, all 8,000 odd cases. You can see majority is from Colombo district, around 25% from Colombo, next Gampaha, because TB is very closely related to the population density. The third highest district is Kandy, then Kalutara, Galle, Ratnapura, Kurunegala. These are our high-risk districts. Then Anuradhapura, Kegalle, likewise. So when we go to northern province, the case numbers are very low because the population density is so low. So this is the percentage contribution by each district. This is the rate. So number-wise, the third place is Kandy. But if we map the rate, first is Colombo and second Gampaha, third Kalutara. So Kandy has gone to a place after even Mana has come up. Because Mana, although small numbers are there, Mana cases are going up. Maybe because of illegal migrants, a lot of young people are diagnosed with TB. So we are exploring why isn't that. So this is the rates by district. So when we take the Western province alone, it is contributing around 43% of total burden. Colombo, Kalutara, Gampaha together. Colombo again around 24-23%, some year 25%. This is 2025 latest figures. From Colombo cases, exactly half is from Colombo Municipal Council. This year it has gone a little bit down, but usually it is exactly 50% of the total cases. So the Colombo Municipal Council area, this is the blue part, and this is RDHS area. So you can imagine the terrain, the amount of the geographic distribution and number of cases. So CMC, the terrain is very small, but the population density is very high. Because of that, you can see in the map also, we are diagnosing more cases from the Colombo Municipal Council area. Earlier, I told that tuberculosis, when we take a country, nationally, the country is not a high burden country because our notification rate is less than 100 per 100,000 population. But we take the CMC alone, the case, you can see that this is the MOH area. We call it as administrative area. So D1 is Modara Matta Kulia area, then D2A Grand Pass New Bazaar. D3 is Boralla, Vanatha, Mulla and Dematagoda. These are numbers. So in my next slide, I have shown the rates here. So this is like exactly like India, even more than India. So 275 per 100,000 population in Modra Mattakulia, then 199 per 100,000 population. So this is the focus. From this focus only, they are spreading the disease all over the country sometimes, because even in estate population, when they come and work here, they get TB and they go and they spread it in the estate area. So these are the two different geographic areas. You can see the Bambalapitia area, and D4 is the Narahimpita. So the case rate is very low. So female to male ratio, as I told you earlier, more males are being diagnosed with TB. So you can see here in the younger age group, 0 to 14 and 15 to 24, the female preponderance is there. But when the age group advances, the blue line came on top of the red line. That means the male preponderance is there, because the reason is not only the exposure is high, but they are carrying lot of risk factors I explained earlier in my third slide. So they are having behavioral risk factors, even biological risk factors, etc. That's why they are presenting more with TB. But the situation is not same when it comes to Colombo and when it goes to Colombo Municipal Council area. So you can see the national figure 1 to 1.8 female to male. The gap between male and female getting narrowed when we come to Colombo, that is 1 to 1.5. It is even narrowed when we go to CMC area, that is 1 to 1.2, almost similar. This is because in CMC, the population is behaving differently. If females are diagnosing more with TB and if children are diagnosing more with TB, that means the community transmission is ongoing. So that is an alert thing. We have to pay more attention, more focus if more females are being diagnosed and more children are being diagnosed with TB. So again, this is the age distribution. You can see we have categorized, this is the usual age categorization. We call pediatric population as 0 to 14, then 15 to 24. Likewise, the more elderly people are being diagnosed with TB now in our country. So if I plot the same thing about 20 years back, I won't get this picture. So more younger population were diagnosed with TB those days, but slowly our TB curve is shifting towards right. So if you take 55 and above age group, the contribution is around 45%. That means that's a good sign. Why I am telling it's a good sign? They must have infected some time back, but because of their low immunity, because they are getting lot of immune deficient situation like CKD, diabetes, etc., they are going for active TB disease now. So this is a sign of TB elimination, but we have to handle the specific area where this younger population are being diagnosed with TB, it's differently. Like Nuwara district, we have to handle it differently. So when we analyze all our 9,000 cases or 8,500 cases, this is how the risk factors are being distributed. So around 20% of TB patients are having diabetes. So that's why we are having discussion with the Ministry of Health, the NCD unit. Do we need to screen TB in diabetic clinic? At least entry point screening at the registration, or then after that, every visit symptom screening. And see, this around 25% of our patients are having BMI less than 18.5. Again, another 25% alcohol use, another 26% smoking. If we take presence of one or more comorbidity, around 35%. So comorbidity has become a big issue in Sri Lanka when handling TB cases, not only for the case burden, but also for the death rate. It has become a huge issue. So this is about drug-resistant TB. Drug-resistant TB is not a big problem in Sri Lanka, fortunately. We are putting our maximum effort to diagnose drug-resistant because now we are having molecular diagnostic tests. We can assess the rifampicin resistant as well, but this is always less than 15. So in that way, we are happy. We are in a good situation when compared to the other countries in the region. So this is our treatment success rate. I want to highlight this because our treatment success rate is coming down. Treatment success rate means if a patient is registered for treatment, at the end of treatment completion, what has happened to the patient? Whether the patient is declared cured, whether the patient is declared as treatment completed. Treatment completed, usually we go for clinically diagnosed TB and extrapulmonary TB, both together treatment success rate. But unfortunately, the success is coming down due to one main reason, that is this red line, that is the death rate or case fatality rate. Our case fatality rate has gone up from 6% in 2010 to 9% maximum in 2023, and after that 8.2 again, now 8.2. So this is a huge problem when controlling TB in Sri Lanka. As I told you earlier, more elderly people have been diagnosed, more people with comorbidities have been diagnosed with TB. That's why this death rate is going up. We are in a critical situation where we can't handle the patients who are presenting late and who are presenting with comorbidities. So I just want to highlight few things about deaths. So we have analyzed the last year 720 deaths. That is in 2024. You can see, as I told you, around 51% are people 65 years and above. As you know, there's a demographic shift in our country. More elderly people are there now. So we have to do everything strategically, targeting the elderly people. That's why even TB interventions, TB case finding should also be revised because most of the elderly may be homebound patients, homebound people. So we have revised our targets, our strategies as per to the need. So again, when we analyze that 720 more were males. So you can see cases male to female ratio, female to male ratio 1.8, but deaths it's 1.1 to 1 to 3. So more males are dying due to TB. Again, BMI less than BMI 58%, and majority of our patients who are dying are new TB patients. That is the worst situation. Not the patients who are registering for retreatment, relapses, but the new patients. Why these new patients are dying? That is our concern. So type of TB, again, unfortunately, majority who are dying are smear positive pulmonary TB, not extrapulmonary TB, not smear negative pulmonary TB, but smear positive pulmonary TB. Infectious TB must be they are coming late, must be they are attending late to the system with full-blown TB. That's why they are dying like that. And another thing I want to highlight, majority, 63% of our deaths has occurred during the intensive phase. That is the first 2 months of the after registration of patient. That means definitely they must have come late with full-blown TB and with lot of comorbidities. So our people, even our chest physicians, they are putting their maximum effort to save life, but unfortunately, they are ending up in deaths. So again, 58% had one or more comorbidities. If we take individual comorbidities, you can see 35% of our deaths, 251 out of 720 had diabetes as a comorbidity. These are less, CKD 9%, chronic liver disease, chronic lung disease around 5.7%. So what I want to highlight is, if we take cases, the percentage of these risk factors you have seen, but if we analyze the deaths further, their contribution is so much high. So alcohol use 38%. Earlier I told alcohol use for cases, it is around 25%. Smoking, around 41% of TB deaths are having smoking as a behavioral issue. Okay. So that is the end of epidemiology. Then we'll slowly move to the next section, that is strategies to end TB. So globally, TB is a very important disease because in other countries, people are, the cases are not like this, not like our country. But because our country is a small country, when compared with other diseases, this case burden is a huge problem for us. And it is not being reduced. That is because it is very closely related to social determinants of health. We need development, we need human development. We need nutrition and all, and poverty alleviation. So there are a lot of things where multi-stakeholder contribution should be there. So we'll see the NTB. What is NTB? What is meant by NTB? We can't eliminate TB or we can't eradicate TB. The goal is NTB, that is to reduce TB incidence 10 per 100,000 population. So there are three indicators. As you all heard, 2030 we are having sustainable development goal. Then 2035 is the NTB target. So the SDG target and NTB target both are talking about TB indicators. The first indicator is we have to reduce 95% of TB deaths compared to 2015 baseline by 2035. This is 90%. The second one, compared to 2015 baseline, we have to reduce TB incidence by 90%. Incidence here is WHO estimate, not actually what we are diagnosing, okay, but not what we are reporting. The third indicator is on out-of-pocket expenditure. We are talking a lot about primary health care, universal health coverage. That's why this indicator is here. Percentage of TB affected household facing catastrophic cost due to TB should be 0. So that should be 0. What is catastrophic cost? If any TB affected family is spending more than 20% of their household income because the TB patient is there, that family is labeled as a family facing catastrophic cost due to TB. More than 20% of their income. So there are costing surveys. Through surveys only, we are estimating this figure. So we'll go to the natural, our figures. When we calculate all these into numbers, you can see 2015, we had 648 deaths. 2023, 780 deaths. Now it's 747. We have to reduce this number of deaths up to less than 50. So 32 deaths, that is the target. Very ambitious. It's not easy. Again, incidence, when we calculate the same into numbers, WHO estimated there should be 13,650 TB cases in 2015. Now the estimate is again 14,000. If we calculate the 62 per 100,000, we should reduce it to at least to 2,000 cases. 1,365 is the target. Catastrophic cost, we didn't have any figure in 2015. 2022, we did a costing survey and found out 16.8%. We had to reduce it to 0%. So you can see these targets are very ambitious. So as a country, if we don't get the support of the government and other stakeholders, reaching this target is not real. Right. So next, the most difficult situation, the most hard situation is, you can see there's a top line, that is the WHO estimate for the country. Usually for each and every country, WHO estimates this is the number of TB cases you should identify. That is through a modeling exercise based on the past data. This white line is the number reported by our country. So there is a gap. If we take 2015 up to now, always there's a gap between WHO estimate, that is around 14,000, and what we diagnose, which is around 8,000 to 9,500 cases. So because of this, there's around 5,000 case gap each year. That means we are missing around 5,000 TB cases each year. So missing cases is a very much concern, because this affects the country's index on universal health coverage. The TB case detection rate has been included as an indicator in UHC index. So it affects the country as a whole if we don't perform in the aspect of TB well. So this gap could be, one is due to we are diagnosing TB but we are not reporting, underreported. Right? So patients are diagnosed, but they don't come to our system for registration. So we will miss the case. The second one is underdiagnosis. So we miss the diagnosis. Sometimes we find them as post-mortem diagnosis. So that's why now we have started the post-mortem TB notification system as well. TB surveillance through the post-mortem TB identification. So this gap we have to fill somehow. That is a great challenge. So let's see what are the strategies available to reduce, to go to these targets. So the first one is to reduce number of deaths, then to reduce number of TB cases, then the catastrophic cost due to TB. So this is reduction of TB incidence. That means to reduce the TB incidence, we can do two things, and we are doing that two things. One is improving passive and active case finding. As you all know, passive means the patient who are coming to us with symptom. Active means we actively go to the field or to the detention center or wherever in prison, and we are trying to identify cases. So both of these mechanisms, we can reduce TB disease transmission, and it will further reduce TB incidence. The second one, screening and treatment of TB infection among high-risk groups like household contacts. It will prevent emergence of new cases. So only identifying cases as much as possible is not enough. At the same time, we have to prevent emergence of new cases using TB preventive therapy. So it will ultimately reduce number of TB cases. So this is the strategy to reduce TB incidence. Then the second one is to reduce TB mortality. What are the strategies available? So I'm very shortly only I have pointed all these things without further elaboration. The first one, we have to empower patients on early treatment seeking. So they will come early to us. The second one, what I'm doing now, I have to empower, we should empower care providers on early detection and referral. So we did a care pathway survey and we found out when a patient gets symptoms, at least within 3 weeks, the patient go to a care provider. I'll tell you what happened later on. So there's a slide on that. And through this, we can reduce mortality. At the same time, earlier I told, we have to manage comorbidities. At the same time, we have to manage adverse events, etc. And finally, it will reduce TB mortality. Then catastrophic cost due to TB. First, improve diagnostic access. So that's why we make treatment accessible and affordable. Even diagnosis also accessible and treatment also accessible and affordable. It will reduce out-of-pocket expenditure. The second one, we have to reduce diagnostic delay. It will reduce multiple encounters with practitioners. Again, reduce out-of-pocket expenditures. Finally, once a patient are diagnosed, we have to improve social protection. For that, we are giving TB allowance for our patients, and it will reduce, sorry. Yeah. So secure household income of diagnosed patients, and finally reduce out-of-pocket expenditure. Right. Now we are moving to the last section of our presentation, that is frontline to finish line, the role of general practitioners in ending TB. So I'll start from the patient pathway analysis we have done in 2000, it's somewhere in 2020. So the survey altogether, there were 743 patients. When we inquired patient, where did you go first? Only 9% of patients said that they went to chest clinics. 52% said that they went to government sector, and 38.8, that means almost 40% said that they went to a private care provider. So when we analyze further the individual care provider, what we found was 27% of our patients, that means around 203 from 743, have gone to part-time providers. The explanation they gave was those were their family doctors. It is very convenient and they are not taking a lot of money. Because of that, they have visited the general practitioners, the part-time practitioners, and also a considerable amount went to full-time general practitioners. However, when we further analyze what happened after the first counter, what we found was the patients who have went 33% of patients, number-wise it's very small, but 68% of the patients who encountered with full-time GP and 69% of patients who encountered with part-time GPs, they just gave symptomatic treatment without doing the investigation. So this is the numbers they send for investigation. That is fairly low. So it was a concern for us. Then what happened? Because based on that, we have included one main objective into our national strategic plan. That is our third objective. This is 2021 to 25 NSP. And again, our new national strategic plan also, we have included this as an objective. That is to properly engage the private sector in TB diagnosis and care and ensure by in 2025, 30% of all referrals from the private sector, including the consultant referral altogether. And we promoted having more communication with the general practitioners. We had a SMS program as well as our DTCOs. We have advised them to form WhatsApp group with the general practitioners. And Private Health Sector Regulatory Council is a member of our MAF-TB framework, that is Multi-Accountability Stakeholder Framework, chaired by the Additional Secretary Public Health Services those days. And we also invited colleges, College of General Practitioners as well. So we did a lot of work, even capacity building, and tried our maximum to make our communication going on with the private sector, all private providers, not only general practitioners and private practitioners, with all private care providers. At the same, I have included few slides on the government hospital view as well, because I know some of you all must be working in OPD setting, must be working in different capacities in government hospital. So this is from the same care pathway survey. You can see provincial district general hospital, around 40% they have given treatment, symptomatic treatment. Base and district hospital, 24% and 47% they have given symptomatic treatment. Although the issue is, although we have established more than 180 microscopic centers in peripheral institutions, the OPD level case diagnosis is very low. Majority of patients have been diagnosed after admitting to the ward. Again, we had a concern whether these patients are coming late or maybe due to some reason those patients are getting admitted. So we explored that also. There's a slide on that, I'll show you. So usually what we say is, in a general OPD, 1 to 2% of all OPD attendants should be presumptive TB. That means TB suspects, those who are having the symptoms I mentioned earlier. But this is the entire year 2024. From our data, there were 12 million OPD attendants. From that, 51% only referred for AFB, that is for sputum microscope. It is just 0.4%. But it should be at least 200,000 or 240,000, something like that. So there's a huge bottleneck here. Presumptive TB referral in the OPD setting is very low. Please send this message to your colleagues also. Always to think about TB. You must be having a lot of people working in the OPD settings. Ask them to think TB even they get a patient. We don't get TB patients now with the exact picture what we learned in our textbooks. The pictures are very different. Sometimes they only present with a fatigability, but we have to get a detailed history like they are having any immune deficient situation or not. So this is the diagnostic access. Actually, we have widespread diagnostic access. Microscopy centers are there, and molecular sites like 29 gene expert sites and 17 TrueNet sites. Both of these are molecular rapid, WHO recommended rapid molecular diagnostic test. And we have our national TB laboratory with culture facilities and intermediate TB labs with culture facilities as well. So the other bottleneck what we found was the medical officers at the outpatient department are not authorized to order x-rays. That's a challenge in our country. There are a lot of explanations for that. I don't want to reveal all these things, but that was a bottleneck when we found it in somewhere in 2024. Because of this, non-implementation of full diagnostic algorithm has been a concern. The second one is all smear negative should be subjected to a molecular diagnostic test if the x-rays are suggestive. So this is our adult diagnostic algorithm. You can see patients with signs and symptoms suggestive of TB, as I explained earlier. Now we have started a triage also with WHO 4 symptom criteria. That is chronic cough, fever more than 2 weeks, loss of weight, and night sweats. Those are the 4 symptom, the WHO 4 symptom criteria. So we have started a triage, and we are trying to push as much as possible presumptive TB patients for diagnosis, because we are going for elimination. We have to reduce the threshold. So we have to reduce the threshold, and we have to examine as much as possible patients. So if a presumptive TB patient is diagnosed, both chest X-ray and AFB should be done, which was not happened earlier for the outpatient. They ended up only with AFB, sometime one AFB, sometime two, patient gone missing, no gene expert afterwards. So I don't have time to explain all these things. So this is the algorithm. So 2 or more sputum AFB positive, or 1 if AFB positive with X-ray, we can start treatment. But if AFB negative but X-ray positive, we have to send the patient for molecular diagnostic test. So that is the algorithm says. And these are the circulars we sent through DGHS. So in 2019, we sent one circular, 2024 again. But what we see now is majority, mainly many hospitals, at least in a like 5 X-rays per day, they are permitting for outpatient departments. Right. So the proposed solution through strengthening private providers, here this is the referral forms we have printed. Our DTCOs are having these referral forms. They should distribute this among all private providers, full-time, part-time, everybody. When they suspect a TB patient, if they can't diagnose, they should refer this patient with this form to either to district chest clinic or to a closed microscopic center. Or else, if you suspect, you can go ahead with a chest X-ray. Reading a chest X-ray is not a difficult task for any medical officer in this country. But if you see any doubt, you can send for reporting in the private sector. Because I'm also doing private practice. Sometimes if I can't read the X-ray, if I see there's some lesions, but I can't explain, then I'm sending that X-ray to the radiologist. You can get it reported from the radiologist. They take only 500 rupees in private sector. That's not a big amount. So you can send either through GP referral form the patient with the chest X-ray, or else without the chest X-ray. So this is the one point I want to highlight to get your support on. Right. The next one, diagnosing pediatric TB. Again, it's a challenging situation because pediatric TB, they behave differently. Manifestations are different from adults. They develop more extrapulmonary disease, and often it's less contagious pulmonary disease. And in small children, the interval between infection and disease is not very wide like in older people. The third one is clinical and radiological manifestations are less specific in children compared to adults. Adults, we know the right apical cavitatory lesion. If we see, we know that is TB. But here the presentation is difficult. Sometimes we get confusion with bacterial pneumonia. And microbiological confirmation is also difficult because they are post-bacillary disease and they can't produce enough bacilli in their sputum. And they can't cough out and give sputum. Because of that, we are usually admitting children and doing the gastric lavage. So that is a challenge. That's why the pediatric TB diagnosis in our country is very less. It's only 3% of total TB cases, but it should be around 5 to 15% of total TB cases. These differences in children makes the approach to diagnosis, treatment, and prevention. That's a unique thing. And there's a separate algorithm for pediatric TB, and it should be displayed in all MOH clinics, MCH clinics, even pediatric clinics and OPD settings. And you can see the criteria for presumptive TB. Cough is there, cough for 2 weeks or more, weight loss, and poor weight gain is also a symptom of presumptive TB. For example, very low weight for age, less than 3 SD, underweight, that means less than 2 SD, or growth curve flattening. Here we have to think this could be TB. We have to get a little bit of detailed history. Always remember to ask a contact history because children getting TB definitely from adults, usually adult in the household. Then pneumonia not responding to antibiotic could be TB. That is also presumptive TB. And poor control of asthma. We have started inhale steroid, but the child is not responding, then think about TB. Then undiagnosed any febrile illness going for more than 2 weeks, and poor feeding, anorexia, less playfulness, all these are presumptive TB symptoms. At the same time, there are some risk factors which is more related to the immune deficiency status like HIV, severe acute malnutrition, immunocompromised children. If these children are presented to you with the signs of repeated respiratory tract infection, please think about TB and take a chest x-ray and refer to the necessary place. So this is how we diagnose the number of TB cases. So around 250 maximum we are diagnosing each year. So majority now, majority is clinically diagnosed. That's why we need an expert to diagnose TB among children in some time. We can see the bacteriologically confirmed proportion is going up because now we are having the molecular diagnostic facilities, and a higher proportion are being diagnosed with extrapulmonary TB as well. So what the proposed solution is to establish referral mechanism through you all, not only MCH clinic and nutrition clinic, but if you encounter these type of children in your private care practice or even in OPD, please refer to a pediatric pulmonologist. They are not available all in the country, throughout the country. Galle, Ratnapura, Kandy, Colombo, few districts we have pediatric pulmonologists, or you can refer to a pediatrician, but please mention query pulmonary TB. Query TB, that is very important because sometimes even pediatricians are not thinking as TB because we are having a very good BCG immunization program, and we always think what we are diagnosing is the real situation, but we exactly don't know is this the correct figure for pediatric TB in our country. A little bit about TB notification. I think the college should initiate this. All general practitioners, even in the outpatient setting or a private setting, should notify patients. So TB is notified only after confirmation, not on suspicion. If we diagnose a patient in OPD, definitely we should notify. There's a special notification form. I would like to suggest not only TB, I think because the Quarantine Act says if a practitioner is diagnosing, that practitioner has to notify other notifiable diseases as well. So we are encountering a lot of patients with measles, chickenpox, and other dengue and other diseases, but we don't do the proper notification. That part we have to initiate because it serves the country in a bigger way. Always the patients encounter the family physicians, family practitioners. That's why I really wanted to suggest that also. Okay, let's move to the next challenge, that is TB preventive therapy. I told you earlier, I showed you a cascade. TB infection, the TB bacilli can be eliminated, or it will go and end up as a dormant stage, that is latent TB infection. So we don't screen latent TB for each and every individual, but high risk people, we definitely screen. So those days, we only tested LTBI for children less than 5 years and people living with HIV. Now there are a lot of risk groups. You can see close contacts of pulmonary TB. Clinically high risk group and other high risk groups like prison inmates, rehabilitation centers, and healthcare workers. Here, clinical high risk groups, those who are taking anti-TNF therapy, receiving dialysis, preparing for organ or hematological transplant, and patient with silicosis. So this is how we are doing screening for latent TB. First, we are identifying the patients. So these are the categories I mentioned earlier. Then we have to evaluate them for active TB. We have to rule out for the active TB disease. Then we should go for the latent TB infection. So active TB disease in evaluation and the latent TB testing is doing together. Otherwise, the patient has to visit again and again. So for the latent TB evaluation, we can use skin test, MANTU test, or CyTB. CyTB is an antigen-based test which is not affected by BCG vaccination. And we also have interferon gamma release assay that is to rule out latent TB infection, but it is costly. Therefore, we are not using widely. We use only for the clinical risk group. We don't do latent TB screening for under 5 children because it is not cost effective. They have got BCG vaccination. For other people, we do the testing, and if the test is positive, we are starting on treatment. Those days we used only INH for 6 months. Now there are shorter regimes. 3 HP means 3 months of INH and rifampicin. We have to give weekly for 3 months. So there are a lot of development in this aspect. So these are the challenges we are encountering. Patients are not coming to us for screening because of the transport cost. They have to bring the entire family. Because of that, we have decentralized screening and evaluation to other hospitals. The base hospital and other hospitals which has X-ray facilities, we have decentralized it. And also the MANTU reading, they do the MANTU, but they don't come for the MANTU reading. In maximum 48 to 72 hours, we have to read this, but they don't come. So not attending for MANTU reading, we are planning to overcome this challenge by training MANTU reading at hospital OPDs, by general practitioners who are closer to them, and by medical officer of health. So this is another point you can help us. And also for the treatment adherence, because they are not having any symptoms, they are asymptomatic. Because of that, they are very reluctant to take treatment. That's a huge issue in treatment adherence. So what we propose is dot provision through a close by general practitioner. Now we are promoting video dots because now everything has been changed. Not physical dot, patient no need to go to a practitioner and take in treatment, but we can do it as a virtual dots. So if we take entire care cascade, so you can see at the point of suspicion and at the point of initial evaluation, this point you can contribute to us. Again, you can have a collection center, sputum collection center if you want, because we are trying our best to establish sputum collection center in Colombo Municipal Council area, the central dispensaries. But we are repeatedly failing. But if we find out any willing private practitioners in that area, they can establish a sputum collection center which needs only a mini fridge. We can provide that also. At the same time, we are having these PICME services. We have launched through a PICME courier service for sputum transportation from these places to microscopic center. And also this stage, the treatment adherence, you can support us by providing DOTS treatment. This is for TB patients, as well as TB is a cascade. It doesn't end until by the time the treatment completion. Some of our patients will end up in post-TB care because they end up in post-TB bronchiectasis. There are a lot of sequelae of treatment because they came late with full-blown TB. Their capacity will go down. So there are a lot of lung issues. So post-TB care is the other point you can be engaged. And again, contact screening and LTBI screening, as I told you earlier, for MANTU reading and CITB reading, we can train the general practitioners. So, and for the treatment adherence part, also that is for the TB preventive therapy, we can get your support. So that is the through the care cascade, the different points you can support us, or you can engage and go to our dream of eliminating TB. So one last slide on new development. This is for knowledge purpose. Now there are a lot of new technologies coming up to facilitate TB diagnosis. We have the CAD for TB software, which we can install to our digital X-ray machines. We have 3 now in the country, one in Navalapitiya, another one in Homagama, and one in Vatupitiwala Hospital, all funded by Global Fund. And also there's ultra portable X-ray. This is for opportunistic screening. So each and every patient which undergo a chest X-ray, they will get screened for TB as well. Suppose pneumonia, they will screen for TB. This is ultra portable X-rays. We receive 2 machines. Altogether, we have 3 ultra portable machines in the country now with AI software. So we can use this in the field, in the prison, detention center, wherever. It is lightweight, around 7.5 kg total weight. And Stool for gene expert. Earlier I told taking sputum and testing sputum from children is very difficult. Therefore, they are now suggesting to go for gene expert testing with stool sample to identify pediatric TB, because they always swallow sputum. We are very familiar with that. They always, when they get a cough, they swallow the sputum. And the next development is swab-based test. WHO, I think it was in the approval pathway. Today I saw that WHO has approved swab-based, means throat swab, tongue swabs. Using those swabs, we are doing point of care or near point of care test. So again, using this TrueNet machines, there are very lightweighted portable TrueNet machines in India. That's a product of Molbio company from India. So they do it in the field. It's a battery operated one. So it's a point of care test. And there are also new development. You must have heard about multi-drug resistant TB. We always said those days, don't get drug resistant TB. You have to take treatment for 2 years. You have to take injectables. Now the entire picture has been changed. Now we have 6 to 9 months shorter regime, all oral. So this is bedaquiline, patenamide, and linezolid, or bedaquiline, patenamide, linezolid, and moxifloxacillin. So again, there are shorter regime for drug sensitive patients. As you know, our normal regime is 6 months regime, 2 months of rifampicin, INH, ethambutol, and pyrazinamide, and 4 months of rifampicin and INH. So here, the DSTB, more than 12-year-old, we can go for 2 months of INH, rifampicin, pyrazinamide, and moxifloxacillin, and again 2 months of INH, rifampicin, and moxifloxacillin. So again 4 months. That's another regime for paucibacillary TB, TB lymphadenitis. That is 2-HRZD, that is the normal thing. And again, not for 4 months, only for 2 months HR. So this is for paucibacillary TB among children. And there are shorter regimes on TB preventive therapy, 3HP, that is INH and rifampicin weekly for 3 months, and INH and rifampicin daily for 3 months. So there are a lot of development in treatment aspect as well. All these things came after COVID-19, with all this new development. And finally, this is my last slide. Projected acceleration of desired decline in global TB incidence rate. To reach 2035 targets, we have to do these things. We have to use point of care tests, new tools, emerging from pipeline, and also we have to introduce TB preventive therapy. On top of that, there should be a TB vaccine. Then only we can bend this curve to go to this situation. Otherwise, it is very difficult. So 10 per 100,000 population is our goal in ending TB 2035. To come to that, we have to reduce, we have to go for targeted interventions, and novel technologies should be applied. Then only it is going to happen. So these are the vaccines. There are a lot of vaccines in pipeline under development. So there are vaccines at this stage. That means patients are not infected, but they are using its prevention of infection for healthcare workers and other high-risk groups. And there's another category, prevention of disease, because they are infected. They want to prevent the disease, so another category of vaccine. And the third category of vaccine is patients have already got the disease, but they want to prevent recurrence. So that is the other one. So these are the vaccines. There are priming vaccine to replace the primary vaccination of BCG. And there's booster vaccine following BCG vaccine, addressing the shortcoming of BCG vaccine. So there are a lot of shortcoming of BCG vaccine. BCG is effective only to prevent complication of TB, like TB meningitis and miliary TB. That's why in pediatric population, TB meningitis is very low. So that is there. Then latent infection, preventive vaccines, and finally the therapeutic one, as I explained earlier. So this is the last few slides are for your information and for your knowledge purpose. If you want to learn more about TB, there's a huge resource platform, that is WHO TB knowledge sharing platform. You can access this and read all the guidelines and whatever the new development, etc., on tuberculosis. I think that's the end of my presentation. Thank you so much. So this is March 1st. On March 24th, we are celebrating the World TB Day. So every year on March 24th, that is the day we discovered and declared the TB bacilli. So this year the theme is yes, we can end TB, led by the countries and powered by people. So led by Sri Lanka, because this is red alert is now globally there are a lot of funding cuts. USAID is not functioning, and there's funding cut for global fund. So because of that, this color they have given, and also the country has to take the responsibility of ending TB. So that's why it is marked as we need to have domestic funding and domestic support, government support, and all stakeholder support, including you all, to end TB. Thank you.
Thank you very much, Dr. Mizaya Cader, for that insightful and informative lecture on tuberculosis. It was truly a valuable and enriching session for all of us. The forum is now open for questions. If you have any questions or comments, please feel free to unmute yourself or post them in the chat box.
Madam, if the person has not come for the mantu reading, can we repeat the mantu, and what is the duration we can repeat the mantu?
Yeah, we can repeat the mantu within 2 to 3 weeks maximum. We can go for repeat mantu.
There are some questions in the chat box, madam.
Yes, I see.
Yeah, how could we do a TB screening in GP level?
Yeah, so GP level, the symptom screening is a must. So we all can do the symptom screening. No, that is at least the 4 symptom. The chronic cough, fever, should be more than 2 weeks, loss of weight, and night sweats. If any one of these symptoms is positive, please refer for a chest X-ray. That's the most important test now. Because earlier I explained about subclinical TB. So even subclinical TB we can diagnose by doing a X-rays. So even nowadays when we do this death reviews, what we found was some patients, their symptoms are not very classical. So vague symptoms, especially the patients with having diabetes, CKD, etc., presenting with vague symptoms, and when we do an X-ray, we find these X-ray lesions. So please do, those 2 are the simplest tests if we want to do at the GP level.
Then there is another question.
Excuse me, madam, patient is on the prednisolone or methylprednisolone. Can we do the mantu test?
Yeah, that means the long-term steroid.
No, if we think about the bronchial asthma and prednisolone 30
we can do the mantu. There's no issue. We can do. Yes.
Thank you.
There are some more
severe
questions.
Immunodeficiencies like CKD patients who are undergoing dialysis, that is one of our category. We do interferon gamma release assay instead of MAN2. IGRA is expensive, but it is compared to MAN2, it is bit sensitive. But in some literature says there's no difference, both are same, but some literature says IGRA is superior to MAN2. Therefore, we are recommending MAN2.
Madam, what are the available drugs as prophylaxis for first contact individuals in a family with TB positive patient? What is the gold standard test for the first contact family members? How often to monitor them? How does the GP notify the TB positive patient? Is there an online form?
Yes, I think for the first thing, I had already made the answer. All those who are household contacts are having the highest risk. So they should go for TB evaluation, that is X-ray, and if they have a cough, the sputum should be done for the gene. We usually do the gene expert. So we exclude TB, and after that we are testing for TB infection. So it is not done as a cascade, one after the other, both together, because we have to minimize number of times the patient is attending to the district chest clinic. So we do X-ray, and at the same time we do MAN2 as well. So usually we are doing the MAN2, that is the test. If the MAN2 is positive, or SciTB is an antigen-based test developed in India, the Serum Institute. Now we are using that also. If the cutoff is different, that is 5 millimeter in SciTB, but in MAN2 it is 10 millimeter usually. If it is positive, we are starting treatment. So what is the gold standard test for first contact? So there is, earlier I mentioned that IGRA is a little bit superior compared to the skin test. But in some literature, it says that both are equal. So there are a lot of research finding, controversial findings. Sometimes the IGRA is superior. So we have two commercial form. One is quantiferon TB test, gold test. The other one is T-spot. In Sri Lanka, we are usually using the quantiferon plus TB test, but it is very expensive in private sector. It's around more than 25,000. Notification. Yeah, this is a good question. We are also thinking to make them notify. So currently the manual notification form is there. But we have the patient information system, which is completely from the point of registration, goes as an electronic system in our chest clinics. They are operating that. Once we register a patient, the notification is generated. Now we are thinking to get that step one before. That means if you diagnose TB, to notify that. So in future, we are planning to adjust our electronic information system, and those who are willing to notify, we are always welcome. We can give the necessary credential to you all, and so that you can notify TB patients.
Madam, if chest X-ray is positive for TB, smear all three negative, can gene expert be done in government sector if GP requests?
Yeah, definitely. If chest X-ray is positive and smear is negative, just refer to the government sector. Just you can straight away refer to the chest physician or a district chest clinic. They will definitely do the gene expert testing, because the X-ray suggestive patients, earlier as I explained, the algorithm won't complete by sputum AFB. Now some countries, the gold standard algorithm is X-ray and gene expert or TrueNAT. X-ray, if X-ray is suggestive, not to do sputum AFB because it's a traditional and very old method with less sensitivity, but we can't discard that because it is less expensive. So that's why still Sri Lanka as a country, we are keeping that. But at the same time, we want to complete the entire algorithm. If smear is positive, definitely you can request for gene expert. Just write to the DTCOs and they will order gene expert.
Madam, early district hospitals acted as smear centers very successfully, but now they are not doing, and we have to refer suspected to tertiary care centers, and patients are reluctant to go. Can we restart those divisional smear centers again?
Yeah, this is about sputum microscopic centers. Currently, we have more than 180, altogether 200 odd microscopic center, 26 in district chest clinic. All the other centers are in the base hospital, district hospitals, and teaching hospitals, district general. So I don't know from where he is. Actually, we can request from our DTCO to establish a microscopy center there. There's no issue. Now we are continuing establishing either microscopy center or collection center. If there is no PHLT in that particular district, you can function as a collection center.
Madam, there's a view telling we talk about the poor support from GPs and OPD doctors in 2000. And today also the situation is not much changed. So the impression is this should be influenced through the ministry with active participation of NPT, CCT, not through circular but more powerful way.
No, we see lot of improvement in the past 3 years. Even OPD referrals, after establishing this triage system, we can see. So the survey report I presented was somewhere in 2020. Even we had lot of work with the GPs now. They are actively presenting for our technical support group, advisory committee, representing everywhere. I think we can improve. A circular is a very powerful tool because it is DG circular. All institutions should abide by that circular. That's why we have circulars. So now we are monitoring the hospitals which are not giving authority for the OPD doctors to order X-rays, and we are presenting it with the DG sir in advisory committees and try to improve that. I have a feeling that we can improve. Now things are changing in different way, not like in 2000. Thank you for that. We
Madam,
don't get the mind.
Madam,
Yeah.
excuse me, what is the price of Cy-TB and gamma interferon? Is it available in government or private sector? Have idea
No.
about the price?
Yeah, gamma interferon is very expensive in private sector. It is more than 25,000. So we are giving for free of charge from the campaign. Even there's a circular saying that the government sector can request, but the better pathway is to refer to a DTCO. If you want to do a gene expert, definitely they will entertain if the X-ray is suggestive, because the chest physician is also there. We can get a second opinion about the chest X-ray, and if the X-ray is suggestive, sputum is negative, definitely we can go for gene expert in the government sector. Sending the patient to private sector is not actually not rational, because it's very, very expensive. Cy-TB is not that expensive. It's around, it's somewhere closer to the Mantu test, around maybe around 300 rupees, something like that. It's not very costly.
Madam,
Thank you very much.
how frequently we need to repeat the screening test for strongly contact with pulmonary TB cases?
No, the issue is if we provide the LTBI treatment for repeated exposures, we are not repeating. LTBI treatment is once, that's it, right? But suppose now we screen, that is negative. If that patient again get another exposure, we can screen them again. And if it is positive, we can start on treatment, but not repeated latent TB treatment, because we always think about drug resistance. That's why we are so reluctant to give this prophylaxis treatment using rifampicin and all. As you know, rifampicin is a drug which specifies drug resistance, multi-drug resistance. So that is a very precious drug. We don't get that kind of connection with DCC. So actually we are monitoring all our DCCs on this aspect. So we have already informed them to have a sort of a WhatsApp group with you all, to share the IEC materials with you all, and we have printed those referral forms and distributed to all district chest clinic. Please contact our DTCOs. I don't know from which district you are, and definitely you can get all those referral forms.
Are there any further questions? If there are no further questions, I would like to make a brief announcement before we conclude. As mentioned at the beginning of the session, all participants who registered will receive their CPD certificate. The attendance details will be forwarded to the ETR branch of the Ministry of Health, and once the necessary notifications are completed, the corresponding eCPD certificate will be sent to your registered email address within 2 weeks. We have now come to the end of today's session. Once again, I would like to extend my sincere gratitude to Dr. Cader for the valuable presentation, and thank you each and everyone for joining us this evening and actively participating. Have a pleasant evening and good night.
Thank you, Dr. Nirukshi, for inviting me. Thank you, everybody, for your interactiveness and the support provided. Thank you. Good night.
Thank you, madam. Good night, madam.